first of all, how try to work well with your scanner. So to understand how everything works, and already Peter Burns excellently exposed it, but to understand the artifacts and the problem, we have to have a little bit knowledge of how ultrasound works. And you are all aware of these problems. The absorbance of the ultrasonic wave depends upon the type of tissue. All of you are aware of this, and transmission frequency according to this formula. So the deeper you are, the more attenuated the coming back waves are, and the less we see. But also at increasing frequency, there is more attenuation, so we see less with higher frequency. Another point that we often have forgotten with conventional ultrasound, since the equipments are working so well, is that the waves are centered and they go in a focus which might be set at different levels, but that microbubbles, even though you're working with low energy acoustic transmission, they do rupture. And this depends on the insonation frequency, so higher frequency, higher rupture of microbubbles, because there is a higher delivery of energy. And also according to the acoustic power, we may work at low acoustic power, but there are different levels of low acoustic power, and also on focusing. So we have to take in consideration all these points. So I tried to make some points on the problems that you might encounter while working. If we'd like to look at a lesion which might be too deep, and the too deep depends on your sort of equipment, but also on the patient's how feasible is the exploration. Attenuation of more superficial portions increase during constant infusion. So if you see something in a bad way, which is because it's too deep with conventional ultrasound, usually if you go with contrast ultrasound, the contrast in the more superficial parts reflects a higher number of waves, and so there is less ultrasound energy which goes in deeper portion, and usually it becomes even worse. So you should not expect to improve your exploration if the lesion is not seen well with conventional ultrasound. For instance, this lesion is about 10 centimeters deep, and we can look at it. This is the late phase exploration, but I repeated this examination because if you are able... How can I start the clip because the mouse doesn't work? We see it now a little bit better, because by the intercostal approach we brought it from 11 centimeters to 7.5 centimeters, and so this had an advantage on the possibility to visualize it. So let's say that one of the first messages: try to have the lesion not too deep. This is another example. This is a subcostal scan of an undetermined lesion identified by CT. The lesion by ultrasound with this approach is about 13 centimeters away, and so an attempt is made to characterize it with CUs. If we go now and we try to explore this portion, you see that the lesion was poorly visible with conventional ultrasound and becomes even worse, too much attenuation. You see how deep is the focus, nearly 15 centimeters. So no way to have more information. Maybe, but not all equipments work at the same level with lower insonation frequency. A lower frequency could have been attempted. You see that you can choose now with the broadband transducers the frequency to be used. So one may wonder, if we make a shot of high energy, high mechanical index, it breaks microbubbles, so we might get information from the microbubbles deep there. They are few, they are distant, but maybe if we break them, we get the information. The problem is that when you're pushing a flash, you're also rupturing the microbubbles in more superficial tissue, and these worsen the possibility of penetration of the waves. So instead of improving the information, usually you have an even worse image. So unfortunately, the rupture of the microbubbles by high mechanical index does not work to have more information. Another point that has to be remembered, that when you are injecting a contrast, you have just a few seconds to get the information. So it's not like conventional ultrasound. You can repeat it 10 times, ask the patients to take the breath inside. You have to have a good cooperation with the patient. So you have to explain exactly to the patient what to do. For instance, this is a nodule which was visible only during forced inspiration, but as we look now, the patient was very anxious about the situation. It was an undetermined lesion, and we are exploring it. Now it starts with the time, so we are waiting for the contrast, but when contrast arrives now, the patient starts to talk, and the target moves away, and when it comes back, we have already lost these 3-4 seconds, very important seconds, when we could have seen what happened during the early arterial phase. And so this information has got lost, and there is no way to recover it. So it is very important that we explain exactly what the patient is expected to do during the examination. So this is the first point. Tell the patient not to talk, to listen at your comments, because the cooperation is very important. And this is another case. You have also to consider this because we don't know exactly when to start the examination. If the lesion can be kept visible for the whole time of the examination, it's perfect. You will see it at any time. But if it is not the case, you have to ask for an inspiration. You have to decide when it is the right time. If it is too early and it is not arrived the contrast when the patient has to release the inspiration, then the lesion moves away, and at the time the contrast arrives, he has not had time to take another inspiration, like it was the case before. But on the other side, you must remember that the examination might, in young patients, what might happen is that contrast arrives very early. We started to look at the image at 11 seconds, but as you've seen here, at 11 seconds, the contrast, the early arterial phase has already started, because this was another young anxious patients, hyperdynamic circulation, and the transit time was very short. So it is important that you start looking possibly not only in the liver, but even the scan you can include also the vena cava or some information on the heart. You have an idea of the transit time between the injection in the arm and the arrival in the heart. And then it takes about 6 to 10 seconds to arrive to the liver. So in this case, more attention should have been paid to monitor the first signs of arrival of contrast to the heart and to the liver, and start earlier the examination. So the take-home messages of these first points are that if the nodule is visible during normal breathing through any acceptable scan, not too deep, then prefer this assess. So you don't need to ask the cooperation to take the inspiration at the right time. Otherwise, if this is not possible before injecting, I recommend to test how long does it take to the patient to take a deep inspiration. You know, there are some old patients which have a little bit of latency between your command and the time when they are able to keep the breath inside. And how does it take to you to identify the lesion? Because some lesions are not so easy to be detected, so you realize that after the inspiration you needed 2 to 3 seconds, and at last, how long can the patient hold the breath inside? Because in some patients you can say, take the breath inside as soon as you inject the contrast, because they keep the breath inside for 40 seconds or 50 seconds. So these are all tiny things that are very important to have a perfect examination. And as last recommendation, at the time of injection, try to include a portion of the heart or inferior vena cava in the CU scan, so you know when the arterial phase is close to start. And keep in mind that in elder patients, circulation times are usually a little bit slower. Then we have to set, this is a cooperation with the patient and the approach. Then we have to set the equipment, because it is not just pushing the button for contrast and everything is perfect. You have to set the total gain compensation and the sectorial compensation gains, the emission frequency, I've told you that you might choose among different ones, the focus depth and acoustic power before injecting. And my recommendation is not to modify them anymore during scanning, because otherwise you could introduce artifacts that you are not aware of. You think you are detecting something useful for the diagnosis, but that might be an artifact. So the aim of all this setting is to have the high sensitivity to contrast concurrently with greatest differentiation of perfusion from tissue, harmonic backscattering scanning fields. If you are not respecting these requirements, you might have false positive persistent of perfusion within an ablated lesion. You might have false positive diagnosis of perfusion where there should not be of portal thrombosis. You might make erroneous diagnosis. You might have reduced sensitivity for slight washout in the late phase of false positive diagnosis of arterial enhancement. If you are investigating high hyperechoic lesions, you modify the setting and you will start picking up the tissue instead of the contrast. How does it change? You see, this is a low-level gain. If you raise the gain, you see that the tissue starts to make some contrast signals. So if we want to detect if, for instance, there is complete necrosis, and we have this information, it becomes difficult to say whether this is bubbles or is tissue. So the first lesson is not to change the gain after you started your examination. When you set it perfectly, keep on with that. So we are now with a contrast scan. That was how it worked without contrast. And if we change the, you see this is an ablated lesion. This is low level of gain, and it seems to work pretty well. If you go with higher levels, you've seen that if this had been the initial setting, it is difficult to say here whether there is perfusion or not, because we have signals here. And in this case, we might not be sure whether there is perfusion or not. So it is very important that you set the gain at the right level. So what is the right level? For sure, this is too low. We don't see the diaphragm. Here we have increased the, you see that the focus is near more or less at the same level. We start to see the diaphragm. This is, at least in my picture, too high. I'm sorry that with this sort of projector, it seems a little bit dark, but it is too high on the screen. And this would be correct. Sorry. Looking at this screen, I would say that this one is the correct one, because you see the diaphragm, so you know that your ultrasound waves goes enough deep, you can see them, and you have information from the vessels. So, as far as I can see it from here, this would be the perfect one. Then we have also to set the acoustic power, because increasing acoustic power increases sensitivity to small amounts of microbubbles and increases penetration. But at the same time, tissue starts to produce echoes at a harmonic frequency, which are difficult then to be distinguished from contrast echoes, and more microbubbles are destroyed, so the contrast lasts less. The mechanical index should remain below 0.3 for real-time contrast investigation. We are all aware of this. But below this threshold, there are many levels at which your equipment may work. And so at least, I must say, below 0.1 are recommended levels, but even below 0.1, you might have different level of acoustic pressure. And I would recommend 50 kilopascal and possibly 40 kilopascal for medium deep lesion. Sorry, this is not 0 point, but it is 50, 40, and 35 for superficial lesion. For superficial lesion, you don't have to go too deep. And the lowest the acoustic power, the longest the persistence of the microbubbles. This is especially true for lesions expected to fill in slowly, like hemangiomas, because in this way, you can pick up the continuous filling in of the lesions. But anyway, what is important is that you test this possibility with your equipments. You should keep in mind that you have the possibility and the duty to change the setting of your equipment. So, for instance, you see here, this is without contrast, and you see that have different acoustic powers, which are not so much different. These are all, let's say, in real-time, low acoustic energy. You get information from the tissue, and it becomes difficult to say whether this is perfusion or not. So what is important to start with the rather low acoustic power, also because of the aim to avoid to have tissue harmonics. And another important point is the focus depth, because moving the focus depth produces changes in the level of grayscale signals displayed, also in the absence of microbubbles. So it is together with the gain, and acoustic power. These three players play together. So you might give more power to one or less to the other one, depending on what you expect from your examination and from the type of examination you are performing, whether you suspect it is a benign lesion, you want to have information on the late phase. If it is very important, the arterial phase, you might have more higher energy because you want to have tiny details of the lesion. So it is important to familiarize with all the settings of the equipment. And it is important because, as I've shown you, at the level of the focus, there is the highest concentration ultrasound beam, so there is the higher disruption of the microbubbles. So in this, we don't change the gain. These are three baseline harmonic images. The focus is rather superficial, very poor information from deep areas. This is the higher level. We don't see the diaphragm, a little bit more. We start to see diaphragm, but if we want to see a deep lesion, we have to have the focus here. So one may say, let's put always the focus here, so we can see everything. But as I can show you, this will be the optimal setting for between these two situations. But if you want to see something superficial, the focus is important. So this is a patient who had an ablation of his lesion. The lesion is here. We go with contrast scanning, and you see that we have the information. Okay, it could be regarded as a good examination. It seems that there is no perfusion within the ablated area. But if we just move the level focus and we don't change anything else, you see that the information is sharper. Everything is more clear. You see how the definition of the border are much more clear. But we lose what happens in deeper portions. I think that all of you can notice the difference between these two images. Here everything is much more clear. I've just moved the focus, nothing else. But I've lost information in the farther portion. So it is important that you know what you are exploring. If you just want to know how these lesions is behaving, keep the focus here. But if you have more lesions to be explored, if you go for detection, put the focus here. So if the set of the focus is too superficial, you may overlook deep lesions. And in late phase scanning, you might not have enough contrast because there is an early excessive disruption. If you put the focus too deep, arterial hypervascularity is less evident, or might be blurred, even in the late phase, in the superficial portions. And you also get noisy signals in superficial lesions. So don't forget that you have to set the right position, the focus, and do not move it during the examination unless you realize that you made a mistake. So the message is, if you go for characterization, put the focus just slightly below the level of the lesion. If you work for detection, you don't have to lose the deepest portion, so set this focus as deep as possible, or as deep as the deepest portion of the liver. In case of portal thrombosis, you have in cirrhotic liver, you have an increase in overall arterial perfusion, and so it is important not to use too much contrast, because otherwise the arterial phase lasts too shortly, because you are flooded with contrast in the arterial phase. So my suggestion is to reduce the contrast volume by about 50–75%. This is the case, and you see that just in a few seconds you have filled completely the parenchyma. At 18 seconds, sometimes you don't still have any arterial perfusion, but in this case, nearly the whole parenchyma is perfused because of the portal thrombosis. Now the liver is perfused only through the artery. But if you reduce the amount of contrast, you enlarge a little bit the time useful for characterizing lesions in cirrhotic liver with thrombosis. Then it is important to familiarize with your recording system in order not to forget to record the clip, because this is a significant mistake. And sometimes it happens that you don't see anything. You have to think about the potential problem, to troubleshoot them. Maybe too energetic preparation, shaking. Maybe it was an old vial and it was a mistake, it was taken, so always discard them at the end of the day. Sometimes the contrast was injected too energetically, and in case you have these T-tubes put the syringe in the straight one, not in the one which has to have a corner before entering, because otherwise you are injecting the bubbles against the wall and they disrupt within the tube instead of going inside. Or sometimes the needle has been displaced and you need to reposition it. Another problem is that sometimes you miss the arterial enhancement. You have, in this case, the possibility that you have missed the target, as it was the case for this patient in which we were too late. And so it is important to have the dual mode display to be sure that you were on the target. And in case of patients who have bad veins, remember that the bolus effect of arterial enhancement can be greatly reduced because you have to inject slowly, otherwise you break very tiny veins. And at last, remember that if you are scanning very longly, you might disrupt the bubbles, and since hemangiomas replenish at a lower rate than the surrounding parenchyma, especially if you are using high acoustic emission or you are using high frequency, you might destroy the bubbles in a quicker way inside the lesion, and this might look like having washout. Just to conclude this examination, it happened to us. This was a friend of mine. She was suspected to have multiple hemangiomas. She was totally healthy, but these were many lesions, so it was unclear what it was. And nobody would like to leave her without stating these are all hemangiomas without a contra-examination. So she was put in the ultrasound room and she underwent ultrasound scanning. You see the arterial phase, it seems to fill in, so this seems to be hemangioma. And we are in the arterial phase, 33 seconds. You've seen there are some others around. They seem to fill in. In this case, we forgot the focus too deep, so it happens everywhere. Okay. But then we just go on in real time on the same lesion for a long time, and in the end, it seemed that it was washing out. So she was submitted to other examinations because we were not so confident that these were really benign. It was really a problem. And at the end, MRI showed that these were typically hemangioma. So some potential source of errors. Maybe this is a slow flow hemangioma. We might have used higher volume of sonogy to make the late phase last longer. And we might have used a lower acoustic emission, and we might have avoided continuous insonation of the lesion because we are disrupting microbubbles for a long time, which is not needed. We just need the arterial phase, and then we might wait a bit. And we have used a too deep focus. So in 2 months, we repeated the examination, and you see that by improving all this setting, we could have, this is lower acoustic energy, but we see that the lesion is superficial enough. We have very good information of the globular pattern. This is typical for hemangioma. And in this way, we could clearly demonstrate there was no washout, but filling in. Here we have 4 minutes. And so the technical problems are to be fixed to get a very good diagnosis and not to make fast diagnosis. Thank you very much for your attention.